There is a doctor whose entire job is to push a wire up through someone's groin and into their heart. He then burns microscopic holes in muscle that is still beating. The patient is awake. The doctor reads a three-dimensional map of the heart on a screen and decides, to the millimeter, which piece of tissue to destroy next. He trained for 14 years to be allowed to do this. By the time he is halfway through his career, the radiation shielding has worn out his spine. He keeps working. He has spent 10 years learning to read this map. Nobody else in the hospital reads it. Level 1, medical student. Tuition runs $40,000 a year, $200,000 in debt by the time you graduate. The cardiovascular block opens in M1. The lecturer puts a strip of paper on the screen, 12 squiggly lines, each labeled with a letter and a number. This, he tells you, is electricity, not a metaphor. Each line is the voltage across the membrane of cardiac cells, recorded from a sticker on someone's skin. The cells fire in a wave. The wave passes through the atria first, then down a single bundle of fibers between the chambers, then out through the ventricles. The strip is the wave. You stare at it. A Mobitz 2 and a third-degree block look the same to you. You scribble notes about intervals you do not understand yet and move on. 2 years later, you are on the internal medicine ward, M3, rounding at 5:30 in the morning. Your patient is 68 years old on telemetry in atrial fibrillation. He has been in this rhythm for 3 weeks. The cardiology team decides to cardiovert him today. You stand at the bedside holding a clipboard. The patient is sedated. The pads go on his chest, one over the sternum, one under the left scapula. The cardiology fellow says clear. The room gets quiet. The shock lands, 200 joules. His chest jumps half an inch off the bed. The monitor blinks once. A clean QRS appears every second. Normal sinus rhythm. The patient does not know what just happened. You stand there with the clipboard. Electricity just rewrote the inside of someone's chest. You do not have words for it yet. That night, one line in your study journal. Cardiovert at 200 biphasic, narrow QRS, sinus rhythm restored. You leave out the part where you stopped breathing for a second. Step 2. CK is in 9 months. The scores still matter. The cardiology-bound students in your class are already comparing shelf grades by the spring of M3. You match into medicine. Level 2. Intern. PGY1. $70,000 a year. Sleep debt that stacks for 3 years. It is 2:11 a.m. You are the cross-cover intern for the medicine service. 68 floor patients, none of whom you have met. Your pager goes off. You call the floor. The nurse says, "Doctor, your patient in room 612 is in rapid AFib. Heart rate 165. Blood pressure 90, over 50. He's diaphoretic." You look at the patient's chart on your laptop. He is 74. He came in for a urinary tract infection. He has no history of AFib. You have 3 options. The first is rate control. Intravenous metoprolol to slow the AV node. The second is rhythm control. Intravenous amiodarone to try and convert him back to sinus. The third is to call the cardiology fellow. You sit at the workstation in the dark hallway. Your fingers hover over the keyboard. Your training tells you that new-onset AFib with hemodynamic compromise in a septic patient is not a textbook case. It is the kind of thing that gets discussed at morbidity conference. The kind of thing where the right answer depends on 6 pieces of information you do not have at 2 a.m. You pick up the phone. The cardiology fellow picks up after 3 rings. She's at home. She's not happy. She is also kind. She asks you about the rate, the pressure, the troponin, the magnesium. Her instructions land in one breath. Load amiodarone. Hold off on beta blockade until you confirm the lactate. Recheck a 12 lead in 20 minutes. Call her back if anything changes. You write the order. The amiodarone starts dripping. At 2:40 a.m., the rate breaks to 120. At 3:10, it breaks to 90. You write a progress note. You sit in the dark hallway and look at the ceiling. In 2 years, you will be the cardiology fellow on the other end of a call like that. You do not know that yet. The ACGME work hour cap is 80 hours a week. The shift cap is 24 plus 4. Most weeks you hit both. Sleep is not something you plan anymore. It happens after call in the gaps. You apply to cardiology. Level 3. Cardiology Fellow. PGY 4. 85,000 a year. 3 years of CCU calls, cath lab rotations, echocardiography reading consults, and the slow process of becoming someone who actually thinks like a cardiologist. A few weeks into PGY4, you rotate through the EP lab for the first time. You are not running anything. You are wearing borrowed clothes. The EP techs find you a clean apron from the rack and walk you into a long, dim room with 3 flat screens on one wall, a procedure table in the middle, and a sleeping patient under a blue drape. The attending is already at the screen. He waves you over. On the wall is a 3-dimensional rendering of a beating heart, not a textbook diagram, a live model generated by a catheter inside the patient's left atrium, refreshed every few seconds. The model is colored. Every cell on the surface of the atrium is painted by when it fires in the cardiac cycle. Red is early, orange is next, green and blue are middle, purple is the latest. Across most of the atrium, the colors flow in an orderly wave, but near one of the 4 pulmonary vein openings, there is a small patch of red that should not be red, 2 millimeters across, out of phase with everything around it. The attending touches the screen. That's her AFib. He looks at you. We're going to kill that spot. You stand there in your borrowed apron. The wall screen is a map of the inside of a person, drawn in real time, with the malfunctioning piece highlighted. You can see to the millimeter the thing that needs to be destroyed. You can see the work. You spend the rest of the rotation reading every EP textbook the program has. The general cardiology fellows in your program who aren't EP bound roll their eyes. You don't care. CEP is one of the most competitive subspecialties in internal medicine. The match, the year you apply, has 150 positions. 98% of them fill. 2 more applications, 2 more boards. The cardiovascular disease certifying exam waits at the end of PGY6. CCEP applications open in the fall of PGY5. You write them at night after the cath lab rotation ends. You match into EP. Level 4. EP Fellow. Year 1. 95,000 a year. 2 years of clinical cardiac electrophysiology, the ACGME required minimum, to be allowed to call yourself an electrophysiologist. The lab is small, 3 big screens, a procedure table, an ultrasound cart, the catheter trolley with 8 drawers, the mapping system console in the corner, with the EP tech behind it. The patient is on the table, sedated, draped, right and left, femoral access already in. The attending is gowned next to you. He is not going to do this part. You are. You hold the transeptal kit. The kit is a long curved sheath with a long, thin needle inside it. The needle has to cross from the right atrium into the left atrium, through the wall between them. The wall is called the fossa ovalis. It is about 1 millimeter thick at its center. You cannot see it directly. You can only see it on the intracardiac echo screen, the catheter inside the heart that shows the wall in real-time grayscale. You advance the sheath up the inferior vena cava into the right atrium, position it against the fossa. The intracardiac echo shows the sheath tenting the wall, pushing it inward but not through. The attending says, good, hold it there. You stop. Now advance the needle. You push the needle out of the sheath into the tented wall. You feel the give as the needle crosses. The intracardiac echo shows the needle in the left atrium. The pressure tracing on the monitor changes from right atrial to left atrial. You did the thing. The published learning curve for transeptal puncture is 25 to 30 cases before it stops being terrifying. You are on case 1. By the end of the 2 years, you have to log at least 175 diagnostic EP studies, 50 AFib ablations, and 30 VT ablations. That's just 3 of the 8 ACGME case minimums. The certificate is not handed out, it is earned in volume. The shielding goes on every morning. The vest weighs 12 pounds. You wear it for 1 to 6 hours per case. 1 in 3 EP physicians will develop temporary or permanent orthopedic disability over the course of their career. You are 28 years old. Then they let you run one alone. Level 5 EP Fellow, Year 2. 100,000 a year. PGY8. It is November. The attending tells you on a Tuesday morning that you are running the next AVNRT case alone. AVNRT, atrioventricular nodal reentrant tachycardia. The most common SVT in adults, a short loop of electrical reentry through two pathways near the AV node, one fast and one slow. The cure is ablating the slow pathway. The published acute success rate is 97 to 98%. The fear is ablating too close to the AV node itself, which sits about a centimeter away from the slow pathway target. Hit the wrong spot, and you give the patient a permanent pacemaker. The patient is a 34-year-old kindergarten teacher who started getting palpitations 2 years ago. The EP study at the start of the case confirms slow-fast AVNRT. The attending walks out of the lab and into the control room behind the leaded glass. He is not scrubbed. You are. You map the AV node area. The slow pathway shows up as a band of low-voltage activity at the floor of the right atrium near Koch's triangle. You advance the ablation catheter to the spot. You deliver a 30-second radio frequency burn at 30 watts. Junctional beats appear on the monitor. The catheter is on the right spot. You give a second burn. You stop. The rhythm breaks. The screen reads sinus. The intracardiac signals show no more reentry. You did not cause heart block. The patient goes home the next morning. You stand in the lab for a moment after the case. The attending walks out of the control room and says nothing in particular about it. The mapper says, "Good job." You take off the apron and hang it back on the rack. The MOC clocks now run in parallel: cardiovascular disease and clinical cardiac electrophysiology, both administered by ABIM. Twice the ongoing requirements for the rest of your career. In the fall of PGY8, job hunting season opens. Academic medical centers email you about junior attending positions. Private equity-backed cardiology groups call your program director and ask who is graduating. Recruiters from places you've never been start sending you contracts to look at. You sign your first contract. Level 6, Junior EP attending. 4 months after fellowship, the blood pressure drops. You're halfway through an AFib ablation on a 62-year-old woman. Routine pulmonary vein isolation, transeptal puncture already done. The monitor reads 90 systolic, then 70, then 60. You look at the screen. The intracardiac echo shows a black crescent next to the heart that wasn't there 2 minutes ago. Pericardial effusion, tamponade physiology. The pericardial sac is filling with blood from a small perforation, and the heart can't expand against it. You stop the ablation. The patient is still under conscious sedation but moving. The nurse already has the pericardiocentesis tray open because she has done this before. You drain it. 18-gauge needle into the subxiphoid space under ultrasound guidance, into the pericardial sac. You pull off 200 milliliters of dark blood. The pressure comes back. The crescent shrinks. You leave the drain in. The case ends. The patient does fine. She goes home in 3 days. Her AFib is gone. She thanks you in clinic 2 weeks later. You are a junior EP attending 4 months in. Total compensation around $700,000 plus or minus your contract. The operative note has only your name on it now. No attending signature above yours. You write what happened. You document the conversation with the family. The one you had after the case, standing in the waiting room as the doctor responsible, not as the fellow. A published reflection from another junior EP attending describes practicing electrophysiology in a silo without the ability to ask for assistance as daunting. A senior partner warned the same author that this transition was the hardest one. You knew about the silo before you signed your contract. You walked the same hospital halls as a fellow for the previous 2 years. The halls are different now. Nobody scrubs in above your name. The lab is different than fellowship. Different mapping platform, catheters you didn't train on, reps from the device companies in the room every case, teaching you the equipment you are already responsible for. Academic or private practice, the cash gap is a few $100,000 a year. The contract you signed locks you into a number you can survive for 3 years. Your volume scales. Level 7. EP Lab Director. 10 plus years out. Total compensation over $1 million a year, sometimes a multiple of that in a private equity-backed group. You are doing a lead extraction. The patient is 67. He had a dual chamber pacemaker implanted 9 years ago. One of the leads is now infected. The infection has been on antibiotics for 6 weeks without clearing, so the lead has to come out. Pacemaker leads, after 9 years inside the superior vena cava, are not pull-out objects. They are encased in scar tissue that fuses them to the wall of the vessel. You introduce a laser sheath. The sheath is a long, flexible tube with a ring of fiber optic emitters at the tip. You advance it down the length of the lid. With each pulse of the laser, the sheath vaporizes a microscopic ring of scar tissue ahead of itself. The lead loosens millimeter by millimeter. You pull on the lead with steady tension while the laser fires. The feared complication is SVC tear. Mortality is as high as 50% if the vessel gives. A cardiothoracic surgeon is gowned next to you at the table, scrubbed in standby. The hybrid OR is set up to convert to an open thoracotomy in under 5 minutes if things go bad. The lead comes out clean. The patient gets a new system on the contralateral side 2 weeks later. The infection clears. You do dozens of these a year. Other EPs in town send you the cases they don't want to do. The lead extractions that have been in for 10 years. The redo AFib ablations. The slow VT cases with structural disease. Your name is on the phone tree under complex EP referral. You have 2,000 patients on remote monitoring under your name. Alerts trickle in every hour of every day. You sign off on the ones the device nurses escalate. The pacemaker that fired a shock at 3 a.m. The lead impedance that crossed the threshold. The patient whose AFib burden tripled this week. Capital decisions land on your desk. Whether to bring pulsed field ablation into the lab, whether to renew the mapping system contract, whether to build a hybrid OR for the extraction volume. Each decision routes millions of dollars across 3 to 5 years. The apron has worn out your lumbar spine. Between cases, you stretch in the lab, one leg up on a stool, hands on your hips, leaning back. 10 years ago, you wanted to be the person other doctors called. You are. Your eye on the map is faster than anyone else's in the building. It is 6 p.m. The last case is on the recovery side. You take off the apron and hang it on the rack. You stretch one leg up on a stool, lean back, and look at the wall screen. The screen still has the 3-dimensional model of your last patient's heart on it. The slow conducting band on the floor of the right atrium, the orderly wave you ablated through. The map is still up because the tech hasn't reset it. You spent a decade learning to read it like this. Now you do. In the chart pile on your desk, there is a card from the woman whose pericardial tamponade you drained 4 years ago. She writes from Florida. She has not had a palpitation since. She thanks you for the rhythm. The card has been on your desk for 3 weeks. You will open it after the next case.